it later if they want.
Okay. Okay. Hello then. I'm Füsun Çuhadaroğlu, the current president of the International Society for Adolescent Psychiatry and Psychology. And we have the honor of having Dr. Marshall Korenblum for today's webinar. And let me introduce him to you. Sorry. Okay. Dr. Marshall Korenblum is an associate professor in the Department of Psychiatry at the University of Toronto, Canada. He has been a practicing child psychiatrist in Toronto for 45 years, specializing in individual psychodynamic therapy with adolescents. For almost 25 years, he was the chief psychiatrist at a community-based child adolescent mental health clinic, the Hinks-Delcrest Center, now the SICKIS Center for Community Mental Health. And he was a consultant to the Division of Youth Psychiatry at Sunnybrook Health Sciences Center, an academic teaching hospital since 1980. He's a passionate believer in public and professional education as a tool to combat stigma in mental health. In July 2024, he retired from direct patient care, but continues to teach, supervise, and consult to various schools and professional organizations. He now has more time to spend with his 6 grandchildren, as well as travel, swim, and listen to jazz. So thank you again, Dr. Marshall Korenblum, and now this floor is yours.
Thank you. Thank you very much, Fusen. It's true. I've been in practice for about 45 years now. Well, retired 1 year ago. I'm going to share with you some thoughts, reflections on my career in adolescent psychiatry. So let me just share my screen. There we go. Can everybody see the slides okay?
Yes.
Yes, okay, good. Okay, so the objectives for today are to share my personal career journey and to share with you as well trends that I've observed in adolescent psychiatry over the past 45 years. Um, I'm not going to dwell too much on my personal career journey. The point of this is not to brag or boast about things that I've done in my career, but more to just give an idea of how a career journey can look, particularly in adolescent psychiatry. So, what have adolescents taught me? Many, many things, but I chose these two quotations to illustrate some points. The real voyage of discovery consists not of seeking new landscapes, but in having new eyes. And something's lost, but something's gained in living every day. That might sound familiar to you because it's from Joni Mitchell's song, Both Sides Now. And these are at least two of the messages that I take away from having worked with adolescents over the years. So, why did I choose adolescent psychiatry in the first place? I was a counselor called a CIT counselor, which stands for Counselors in Training, at a sleepover camp in Northern Ontario, which meant that I was in charge of about 40 16-year-olds, 20 girls and 20 boys. And there were two experiences that stood out for me and had a big impact. One was baseball is a fairly big sport in North America. By the way, I should put a caveat for all the listeners from Europe and Australia, if there are any abroad. This is from a North American experience, so I apologize for that. Um, so we were having an end of summer, end of season baseball game between two teams. The CITs, the 16-year-olds, had divided themselves up into Team A and Team B. And there we are at the baseball game, and there was a lot of hype about it. And the score was tied, and it was the bottom of the ninth inning, which means pretty much the end of the game. There was one more chance for Team B to go ahead. So a batter, a male batter, goes up to bat, and everybody's cheering. Team A is cheering for their side. Team B is cheering for their side. The pitcher winds up to send the ball towards the batter, and before the batter can hit the ball, he falls down, collapses, and starts to shake violently. In other words, he's having a seizure. So we all freaked out. We didn't know what to do. They were 16. I was maybe 21. I was their counselor. We immediately called for 911. This was in Halliburton, Ontario. Fortunately, a hospital was close by. Ambulance came, picked up the young lad, did some examinations on him, in particular an EEG. And the neurologist came out to all of us and at the end of his examination said, this boy did not have a seizure. And we said, what? We said, but we saw it. He fell down. He started to shake. He appeared to have lost consciousness. No, the neurologist said, there's no evidence of a seizure. And we got him there pretty quickly. We got him there within about 10 minutes to the hospital. No evidence of a seizure. His neurological exam is completely normal. This was a psychological event. In other words, a psychogenic seizure. Just put yourself on mute. Put yourself on, Debbie, put
Uh,
yourself on mute.
uh,
Put yourself on mute, everyone.
yeah.
Yeah, thank you. So the neurologist said it was a psychogenic seizure. Well, I was floored and I had never heard about this. And the fact that the mind could have such a powerful impact on the body under stress both frightened me and fascinated me. So that was one experience. The other, the same summer, the same camp. Um, so as you heard, I was the counselor for both boys and girls. They've since changed that. There's a separate boys CIT counselor, girls CIT counselor. And part of my job as counselor was to do rounds, in a sense, check up on them and make sure that they were in the cabins that they were supposed to be. With the agreement and consent of the girls, I was allowed to knock on the door of the girls' CIT cabin to make sure that in the middle of the day, nobody should be there. So I knocked on the door, entered, and nobody was supposed to be there because they're all supposed to be working out at their cabins. And to my surprise, two girls were there. They were half naked, and they were making out. They were kissing. So they were doubly embarrassed. First of all, they shouldn't have been there. It meant they were goofing off and not doing their job. And also, the year for this would have been early 70s, 1970s. Yes, before I was a medical student, because I had to stop going to camp for medical school. Early 70s, two girls kissing. No, not allowed. And as I learned, the policy of the camp was, well, for sure, no sexual relationships between staff and campers, but amongst the CITs, you were not supposed to have a sexual relationship either. I felt I had to report this to the head of the camp because they were at least derelict in their duty. And the director was he would have asked me, well, what were the two girls doing in the cabin? So I told the truth. Um, as a result, the two girls were fired. They were fired for dereliction of duty, and also you were not supposed to be having a sexual relationship. I was traumatized by that incident, and to this day, I wonder if I should have reported them or not. They were fired. They were never allowed to come back to camp as counselors. So, as the rest of my slide says, to cope with the discomfort awe and wonder of the adolescent experience, I decided, and that would have been just before going into medical school, I want to learn more about the adolescent psyche. Both of these incidents, the psychogenic seizure and the trauma over the two girls who were making out, fascinated and frightened me. So, to better understand the canaries down the mine, um, and also I thought if I am going to go into medicine and I am going to go into psychiatry, and I was thinking of child and adolescent psychiatry, I like adolescents because they're old enough to talk. So I wasn't so good at doing play therapy, but they're young enough to have lots of neuroplasticity. And one of the rewards I've had over the years of adolescent psychiatry is it's actually pretty easy to make changes in adolescents, and they change fairly quickly compared to adults whose brains are already crusty like mine. Um, okay, so that's why I went into adolescent psychiatry. Now, in child and adolescent psychiatry, we often draw genograms of the patient. Here, what I've done is I've made a genogram and I've made the patient child psychiatry itself. And I put date of birth 1971 because that's when the University of Toronto designed really the first curriculum for postgraduate trainees in Canada. And that was under the leadership of Paul Steinhauer, who was our training director at the time. And so you can see I've made the father of child psychiatry pediatrics and the mother, if you will, general adult psychiatry, because that's what really child and adolescent psychiatry is. It's a mix, it's a blend of general adult psychiatry. We all deal with parents, so we have to know our adult psychiatry in case the parents are mentally disturbed. And of course, we have to know all about development, and that's where pediatrics comes in. So the combination of pediatrics and general adult psychiatry really results in child and adolescent psychiatry. And I don't have to review the history of specialization and credentialing in Canada, but suffice it to say that child psychiatry today is a recognized subspecialty across Canada. So there's a separate exam now for child psychiatry from the Royal College. I was fortunate enough to succeed Paul Steinhauer as the training director when he stepped down. And within child psychiatry, there isn't a recognized subspecialty of adolescent, but you can choose in an elective way to subspecialize in adolescent psychiatry, and that's what I did. You can see that the aunts and the uncles, so to speak, of child and adolescent psychiatry are psychology, education, social work, juvenile justice, genetics, and what used to be called mental retardation, now developmental delay. All of these domains, fields, have an impact on child and adolescent psychiatry, and that's why we have to have some knowledge of those fields as well. So, how did my career go? Well, my first job was actually also my last job. What I mean is, I stayed in these two positions from 1980 to 2024 when I retired. My first job was as a staff psychiatrist at the then CM Hinks Treatment Center, where I joined the Adolescent Clinical Investigation Unit under the leadership and tutelage of Dr. Harvey Gollenbeck, who was my supervisor as a resident and has been my mentor and friend ever since. And I also joined the staff at Sunnybrook Health Sciences Center in the Division of Youth Psychiatry, where Dr. Bob Stein was my supervisor, teacher, mentor, and has remained my friend as well. Both of these positions focused on the outpatient assessment and treatment of adolescents with mood disorder, but also general assessments of teenagers. And so I stayed in both of those positions for my whole career. How did I get involved more in adolescent psychiatry? So, just very quickly, some highlights. In 1982, I became the founding president of the Toronto Society for Adolescent Psychiatry, which was a chapter of ASAPP, the American Society for Adolescent Psychiatry. We then set up a national membership. So I became the chairman of the section of youth psychiatry of the Canadian Psychiatric Association and president of the Canadian Society for Youth Psychiatry. In 1987, I joined the ASAPP, the American Society DSM-4 Committee on Diagnosis. In the 90s, I joined the Society for Advancement of Research in Adolescence in Canada, became the co-chairman of the Council on Education and Scientific Issues. Then I did get interested in credentialing and qualifying, so I became an examiner for the American Board of Adolescent Psychiatry, also a member of the fellowship committee. And then I joined a subcommittee of ASAPP called Teen Troubles, which was headed by Max Sugar. And that was responsible for disseminating education about adolescent disorders to the general public. And that really planted a seed in me of how important public and professional education are when it comes to adolescent psychiatry. I've done some research, publishing mainly in three areas: the relationship between mood disorder and personality disorder, consistency and change in personality from early to late adolescence in a non-clinical sample. This was the principal investigator was Harvey Gollenbeck, and we published a number of book chapters and papers called the Toronto Adolescent Longitudinal Study, which was a prospective longitudinal study of personality development in non-clinical kids. And borderline personality disorder. I published some papers with my colleague Stan Kuchar in that area. Um, Perhaps more interesting was I took a sabbatical, and I would encourage anyone in adolescent psychiatry to get a global. I now am sensitized to the importance of global mental health. So for a year, I did mainly two things. I spent 3 months in Geneva consulting to the WHO. Um, and at the WHO, I was part of a working group who co-developed a mental health promotion program called Helping Adolescents Thrive. And this was meant for low and middle income countries, or LMIC in WHO lingo. And here's a nice little whatever happened to story. So this was in 2017-18. So what, maybe 7, 8 years ago. In March of this year, I attended virtually a rounds from Toronto here, put on by PAHO, the Pan American Health Organization. And it was on suicide prevention, but I didn't know exactly who the speakers were going to be. All of a sudden, so the initiative that I was involved in went by the acronym HAT, HAT, Helping Adolescents Thrive. And we were just developing it at the time. Lo and behold, Dr. Andrei Spiridou presents at this rounds in March of this year something called Fostering Life Skills in Young People to Prevent Suicide, Challenges and Opportunities, Integrating Socio-Emotional Skills into School Curricula using the HAT approach. And what I discovered was not only did the project continue, it thrived and turned into a fully approved program. It switched from being under the WHO to UNICEF, and it's now fully implemented in Chile and other countries in South America, where it's included in all high school curricula. Mental health and pedagogy is accepted, and there was a toolkit developed called the HAT Toolkit. Anyways, my point is sometimes it takes 6, 7 years for a seed to grow and fully go into bloom. But there it is. I discovered just this year that something I was involved in 7 or 8 years later has come to fruition and is actually being implemented in Chile and other countries in South America. So talk about delayed gratification. Wow. But I got a reward. At the same time, while I was in Geneva, I consulted to a hospital in Lausanne, Switzerland, where I became involved as a coder for the adolescent project of Lausanne Trilog Play. That was for 3 months, and then I moved to Australia, and I was in Australia for 6 months, 3 months in Melbourne, 3 months in Sydney. At Melbourne, I was a visiting scholar at Origin, which is the National Centre of Excellence in Youth Mental Health at the University of Melbourne, where I had the privilege and honor of working with Dr. Andrew Chanin. Now, for anybody who works in the field of borderline personality, you'll recognize Andrew's name. He's been a pioneer in particularly the diagnosis and assessment of borderline personality. And I joined his team called the HYPE team for helping young people early. And what I learned there was in Australia, they're not afraid to diagnose borderline personality in patients as young as 12. So they have no hesitation at all in giving 12-year-olds a full-on diagnosis of borderline personality. So I learned a lot about development, early intervention for borderline, and it was quite an honor and a privilege. And then I was also a visiting scholar at the Brain and Mind Center at the University of Sydney, where I worked with Dr. Michael Dudley at the Prince of Wales Hospital as a member of that team. Also internationally, I had the pleasure of working with Fusen. She was kind enough to invite me as a keynote speaker at the Symposium on Adolescent Psychiatry in 2019, held in Kayseri, Turkey. So, how has this all gone? Well, I stepped down from chief psychiatry position in 2022. I retired from all direct patient work in 2024, but I maintain currently an active teaching and consulting role through the University of Toronto. And as an example, I'm a member of the expert advisory panel of the Advocacy Forum for the Division of Child and Youth Mental Health at the University of Toronto. We just had our first meeting 2 nights ago, and this is going to be taking up advocacy to the public, to the government for issues in adolescent psychiatry. We're going to lobby our members of parliament, taking position papers, publishing op-eds. So I'm still pretty active. My wife says I'm only one quarter retired. All right, enough of me, enough about me. So, what have I observed? What trends have I observed over the last 45 years? I'm going to divide this up into things that have increased or gone up, things that have decreased or gone down, and things that have just changed, neither going up or down. And since I have the privilege of being with you today, not only am I going to look backwards through the retrospectoscope, but I'm also going to give some speculations about how the future of adolescent psychiatry might work, looking through the prospectoscope, if you will. So, to begin with, what has increased over the last 45 years? The number of diagnoses. This is not specific, obviously, to adolescents, it's all of psychiatry. But have a look at this. DSM-1 was published in 1952. How many disorders were there in 1952? 60. And actually, if you go back even further to the 1800s, there were six mental disorders. From 1850 to about 1925, there were only six diagnoses. They all had to do with mental retardation or neurodevelopmental things. So that's DSM-1. Now, quickly fast forward to DSM-5 TR, which is the text revision, the most recent one, 2022, 450 diagnoses. This is ridiculous, in my opinion. And in particular, we've seen a huge upsurge in autism diagnoses and ADHD. So, what do we make of this? I call this the democratization of knowledge. In other words, now, because of the internet, knowledge is so widely and freely accessible and available. On the one hand, it's good. There are good things about the democratization of knowledge. Destigmatization. Fantastic. This is great. Increased disease awareness. Also fantastic. We've kind of normalized mental illness, meaning it's okay to be not okay. And when people are less stigmatized, they're more likely to seek help, which is all great. So those are all great things. But has the pendulum swung too far? Therapy speak is now ubiquitous. Okay. I've had many adolescents come into my office saying, Dr. Kornblum, I think I have borderline personality disorder. What? How do you even know that term? And why would you ask me that? Oh, well, if you do Google it on the internet, DSM comes up, and yeah, I think I have 5 out of 9 symptoms. Oh my goodness. Has the pendulum swung too far? Maybe we've gone from disease awareness to disease creation. And we have these new terms now like gaslighting, trauma bonds that we never had before. And I think we've gone too far in the sense that now we are pathologizing probably what's normal. Okay. And some kids are even using a diagnosis for secondary gain. Their identity is tied to pick your diagnosis, whatever diagnosis is, that's who I am. Because of this, we see an increase in fragility. These diagnoses, I get a lot of requests for at school accommodations, meaning there should be exceptions made for them. Somehow the burden should be lighter or something like that, because now they have a label. This discomfort with discomfort in other words, pathologizing normality, I think, and has led to the need for so-called safe spaces. So now in universities and meetings, we have trigger warnings. And in the United States, it's gone so far as to ban certain books because of trauma, the impact of possible trauma. The really downside of this is a lot of attention and care is going maybe to those folks who have only mild illness or don't even need it. Other implications of this are we have seen over the last 20 years, for sure, lots of diagnostic fads. I don't know if you've heard of TikTok ticks, but in Canada, in March of 1921, so right in the midst, the peak of COVID, there were a number of girls in Alberta, one of our provinces, who suddenly had the sudden explosive onset of tics. And in 2021, the keywords hashtag tick and hashtag Tourette's had more than 5 billion views worldwide. Okay. The 28 most popular videos on ticks had more than 300 million views. Okay. The ticks were very atypical. You would have 29 ticks per minute, whereas normally it's about 0 to 13. Lots of coprolalia, lots of self-injury, explosive onset. None of this amounted to organic ticks. Um, and as soon as the exposure, it was all started by one girl who decided to go on TikTok. It was contagion, social contagion. And as soon as it was revealed, guess what? All the ticks rather disappeared without any treatment. Another consequence of all this overdiagnosis, diagnostic inflation, big controversy, particularly in the States, about over medication, particularly with ADHD. Are we over medicating kids? That's a danger. If you're all of a sudden, if 10%, 15%,
Speak close to the door, you'll have to turn the sound off. I won't. Thanks.
you have to put yourself on mute, please, everybody. Um, a big controversy has been over medication, particularly with ADHD. And then a very controversial one, of course, is gender dysphoria or gender incongruence. We now, as in the last 10 years, perhaps, this phenomenon of so-called rapid onset gender dysphoria or ROGT, which is the post-pubertal onset of gender dysphoria. And lots of people are wondering if this is partly, and I realize I'm stepping into controversial area here, partly artifactual, as again, a consequence of social contagion. And some people have wondered if gender dysphoria is the latest idiom of distress. Um, I do not doubt that GID, gender identity disorder, is real and legitimate. I'm not questioning that. What I'm saying is we now have kind of two subcategories. One is prepubertal onset and one is postpubertal onset. And I think we need to do more research. But in this context, my caution is this another example of diagnostic inflation?
Mm.
COVID, for sure, of course, has had a huge impact on adolescent psychiatry. All of us practicing during COVID saw an increase in eating disorders and disordered eating, an increase in internet addiction and video gaming, increase in anxiety and depression around the world. This was a global phenomenon. Increase in self-harm and suicidality, resulting in an increase in hospital admissions, increase in social isolation because of the closures and shutdowns, and terrible, terrible loss of rites of passage. If I had to look back and say which adolescents of my practice were most affected by COVID, I'd probably say the grade 12 or 17-year-olds because they couldn't graduate. And those are rites of passage or milestones you can never get back. So the prom, the commencement, conferences, meetings, and the graduation ceremonies, we couldn't do that during COVID. Terrible, terrible losses. But what some people forget, now that we have some distance from COVID, did anybody do okay and in fact maybe do better during COVID? And the answer is yes. Perhaps 25%, as many as 25% of kids actually, their mental health improved. Why? Who were they? kids on the autism spectrum and kids with social anxiety disorder didn't have to go to school and therefore didn't have to be faced every day with their social skills deficits. They loved being online. Kids who were victims of in-person bullying, now they didn't have to face their bullies anymore. They weren't going to get teased or excluded, or the boys often physically tormented and tortured. They didn't have to go to school. Hurrah, what a relief. Kids who were technophiles and who were already ahead of the curve, if you will, loving computers, they were in their element with COVID. And the kids with OCD, who everybody thought they were crazy for being germaphobes, now felt validated. Everybody had to wash their hands, wear masks, and it was kind of like collectively they were saying, see, we were right. And so a lot of the kids with OCD felt validated. And of course, another upside from COVID was it revolutionized our approach to online learning, teaching, and increased the accessibility to mental health care with online therapy. And exactly what I'm doing with you today probably wouldn't have happened maybe if it hadn't been for COVID. However, no question, and we're still seeing this today, increased stress and burnout amongst caregivers. And COVID really played a factor in this. Teachers, parents, psychotherapists, doctors were hugely stressed by the intensity of having to give care during COVID. And the reasons for this are numerous, government cutbacks. The money all had to go to ICUs, caring for medically ill folks during COVID, which meant less money elsewhere. Technology has since displaced workers in multiple domains. We had a recession, competition for attention, too much to do and not enough time. And with COVID, shifting expectations at home and on the job. And we're seeing this today in Canada, anyways. A lot of companies now are mandating people to go back to work in the office. And there's kind of a mini rebellion against that because everybody's realized how convenient it is to work from home. So we're having echoes and ripples of COVID. Sadly, suicide remains the second most common cause of death amongst 15 to 19-year-olds, and it's the third leading cause of death for 10 to 14-year-olds. In the since COVID, so last 5 years, suicide rates have actually gone up for girls and for 2S LGBTQ plus youth. And, very disturbing, 25% in one survey of 2S LGBTQ youth had suicidal ideation in the previous year, compared to only 5% of their heterosexual cisgendered peers. So the marginalized youth have continued to suffer post-COVID. Here's an interesting statistic from the Canadian Institute for Health Information. How have kids changed in where they're seeking help for mental health in the last 5 years? Now, this covers a wide age span, actually from 5 to 24-year-olds. One thing I would mention is that in Canada, we have something called Kids Help Phone Line, which is a distress center call. And in the last 5 years, they've had more than 23 million online interactions since COVID. Used to be phone only. And again, since COVID, it's gone to text or messaging. In 2024, 5% of emergency visits were for mental health reasons. 20% of those who do visit are admitted. So if you look here, this is the net change, percentage change from 2019 to 24. ER visits have gone down for mental health by 31%. Admissions to hospital have gone down 23%. Visits to pediatricians and general practitioners have gone up by 8%. Medications for depression and anxiety on an outpatient basis up 18%, and medications for psychosis up 13%. So there's been a changing pattern of where help is being sought from hospitals and emergency rooms to outpatient pediatricians and GPs. I think that's a good thing. So changing pattern of where help is sought. Ah, yes. What have I seen in the last 5 to 10 to 45 years? And this is in my outpatient adolescent practice. I've seen a huge increase in perfectionism, posting, and misogyny. First, perfectionism. Amongst both parents and teenagers, I've seen an increase in the need to be perfect, perfect in appearance, perfect in achievement. This is absolutely rampant amongst the upper class, so folks with money, private schools, and medical schools. Perfectionism is, I would say, malignant because perfectionism in its extreme can lead to suicidal thinking. An example of this need to be perfect in appearance is a new term that I just learned a few months ago called looksmaxing, which means maximizing the optimum of how you can look. And there's a whole bunch of new things out there. One is mewing. Okay, mewing is meant for boys. You push your tongue against the roof of your mouth, and this is supposed to make the muscles of your jaw, the masseter muscles, more prominent, which gives you a more sculpted or square-like jawline, and is supposed to make you look more masculine, more attractive. P.S. It doesn't work. But lots of boys are now practicing pushing their tongue up against the roof of their mouth. Bone smashing. Boys, again, are taking hammers, hammering their foreheads to try and give themselves a more prominent forehead and a more square face. Leg lengthening. Again, the bones in the leg are smashed, reset, and in order to make yourself taller. Okay. Dieting, both boys and girls, except in opposite directions. The girls want to lose weight, the boys want to gain weight. And so to bulk up and buff up and look bigger, boys are abusing steroids. Plastic surgery, both boys and girls. Absolutely ludicrous and ridiculous extremes. I had two female patients, one 16, one 18, who wanted to have plastic surgery on their vaginas because they thought their vagina was not the way it was supposed to be. I have no idea what that is. But fortunately, I was able to stop them from going ahead with it. But they were going to subject themselves to basically genital mutilation because of some fantasized model of perfection for how your vagina is supposed to look. Um, yeah, lots of requests for plastic surgery. So that's perfectionism. Posting. Since the advent of the smartphone, teenagers now have an insatiable need to be seen and heard and to see and hear others. And I think this is terrible. The question is why? And I think what we have to appreciate is the internet's power to amplify each person's desire for recognition contributes to its acting as a forum for unbridled narcissism, exhibitionism, and voyeurism. This is the internet. And I wonder if this need for recognition is a pursuit of fame as a defense against existential loneliness, feelings of neglect, and meaninglessness. In my opinion, what this has resulted in is an attention addiction disorder. It's not in DSM, but I call it attention addiction, an inability to handle rejection, criticism, or failure. And if you think about it in historical terms, whereas privacy used to be the coveted value of the bourgeoisie, who defined freedom in terms of autonomy and exclusivity, now access is the most prized value of millennials and those who are younger. They define freedom in terms of the breadth and depth of relationships. So we've replaced exclusivity, that used to be the hallmark of privilege, with inclusivity. Exclusivity no more, inclusivity now. And so we probably have to revise Descartes' famous saying because the kids nowadays say, I am connected, therefore I exist. The corollary is if I'm not connected, I don't exist. And my quandary as a psychotherapist is how do you maintain a differentiated sense of self when you are embedded in an ever more integrated relational web? And some people have called this mass intimacy, which is, of course, a contradiction in terms. All right, so that's all about posting. My goodness, misogyny. What is happening to adolescent boys today? Teens today And this is in reference to the Netflix show Adolescence, which I strongly encourage all of you to watch if you haven't. It will scare the pants off of you, but it's necessary. Um, Teens today are overprotected in the real world and underprotected in the online world. So, misogyny. 82% of Canadian parents of boys, teenage boys, don't even know what the manosphere is. The manosphere is really a varied collection of websites, blogs, and online forums which promote masculinity, misogyny, and opposition to feminism. The philosophy of the manosphere is that men are the oppressed gender in society and they are victims who must fight to protect themselves. This danger is hiding in plain sight. Okay. We think that our kids are safe when they go into their bedrooms and they're, online, but as you can see in the movie Adolescence, it's not true. This has resulted in a huge increase, what I've noticed, in cyberbullying based on the kid being different. And it could be different on any basis. This is othering, and especially when adults are absent. In misogyny, it's females that are different and therefore they're cyberbullied. The dynamics here are shame, humiliation, gain prestige, in other words, to be the alpha male, sometimes revenge if the boy has been rejected. And the danger here of cyberbullying is magnified by the anonymity of cyberbullying and the speed. Okay. This misogyny has had a huge negative impact in schools. Female teachers in Halifax, Canada, have heard this from their grade 9 and 10 students. Shut up and make me a sandwich. Or, I don't have to listen to you. Go get the man in charge. These are direct quotes from the manosphere. And in a minute, I'll tell you where it's coming from. Female teachers in Australia and the UK are leaving the teaching profession because of the verbal abuse that they are getting from their male students. Misogyny, I think I alluded to this before, but particularly in boys, both boys and girls, puts a very distorted emphasis on appearance and sexual prowess or success or lack thereof. And that's where we come upon incels, which stands for involuntary celibates. These are boys who have not been sexually active and they blame women for this. So I think I've seen a huge increase in body image disturbance and body dysmorphia. Mirror image on cultural pressures on girls. For girls, it's to be thin, and for boys, it's to be buff and big. But in this case, for misogyny, men are the victims, which leads to anger at women. 21% of little kids, these are 7 to 11-year-old British boys, have heard of Andrew Tate. 28% of Australian boys look up to him. Who is Andrew Tate? He's a 39-year-old American-British manfluencer who promotes a hyper macho view of masculinity. He's a former professional kickboxer and entrepreneur. And in 2023, he was the third most Googled person in the world with almost 11 million followers on Twitter or X. He's also been charged with, not convicted of, but charged with rape, human trafficking, sex with a minor, money laundering, forming an organized crime group to sexually exploit women in both Romania and the UK. This is Andrew Tate, and 21% of British boys have heard of him. 28% of Australian boys look up to him. His videos have been viewed 11 billion times, and his YouTube channel gets 450 million views. All right. So that's what's gone up. Now, what's gone down in my observation in the last 45 years? We're going to go a little longer than 9:30, folks. So I'm okay to go longer.
That's okay.
Yeah? Okay. What's gone down? Well, the age of onset of puberty. Not new. This has been going on for about 100 years, but continuing for sure in the last 40, 45 years. Lower and lower, earlier and earlier age of onset of puberty. There have been lots of speculations as to why. We know that the percentage of adipose tissue in the body is a trigger for puberty. So there's been a concurrent increase in obesity. And some folks are wondering, is there maybe not a causation, but a correlation between increase in obesity and earlier age of onset of puberty? Other folks have wondered if we're polluting ourselves with all these hormone disruptors, microplastics in that we're eating, affecting both the adrenal glands and the brain. And there is some evidence for that. What else has gone down? The age of onset of mental illness. 50% by 14, 70% by age of 20. I'm seeing younger and younger kids, earlier and earlier age of severe mental illness, particularly eating disorders. Um, and I think that's the canaries down the mine. The adolescents are sentinels for stress in society. Fertility rates, this is not directly adolescent psychiatry, but indirectly, have gone down. Global phenomenon around the world, particularly in developed countries. And this is an inverse correlation with the age of marriage and the onset of childbearing, which has gone up. So girls are waiting longer and longer to get married. They're waiting longer and longer to have kids. And perhaps concurrent with that, their ability to conceive has gone down. And I think as adolescent psychiatrists, we just need to be aware of that. What else has gone down? Unfortunately, very discouraging to me, access to mental health assessment and treatment. In Canada, for sure, we have longer waiting lists, government funding cutbacks, more trends to privatization of mental health. We're on the cusp of a huge wave of retirements amongst mental health professionals, psychologists, social workers, psychiatrists, as the baby boomers age, including myself. And this is causing burnout, huge burnout amongst teachers and doctors and other professionals who are quitting or leaving the profession. And so access to mental health is decreasing. Again, to my chagrin and unhappiness, I believe that emphasis on training in psychotherapy has also gone down. And this is in direct correlation, I think, with an increase in emphasis on psychopharmacology, treating mental illness with medication. So, one of the things I'm going to advocate for in my post-retirement life is to continue making sure that at the national accreditation level, psychotherapy objectives are continue to be important. Neither increasing nor decreasing, but just different. As us, I'm including myself here, us clinicians get older and we get grayer, what I heard was from colleagues, aren't you too old to be seeing teenagers as I get older? And my emphatic answer is no. And here I want to mention something called grandparent transference. So as I got older, instead of getting parent transference from my teenage patients, I started getting transference that was projected from their experiences with their grandparents. And I would say the vast majority of that transference has been positive. If a teenager names some musical group to me and I don't recognize the name, and I go, I'm sorry, I don't know what that is. Can you tell me about it? Teenagers love to be in a position where they know more than the adult. And so they love to teach me, yeah, this group is this and this group is that, or this movie star or this rock star, whatever. They love to be teachers. And so in some ways, I'm more ignorant than them. But in many other ways, particularly in life, I'm more experienced than them. And the more experience you have, the more credibility you have. So the short answer is, am I too old to be seeing teenagers? Absolutely not. And I'm getting less rebellion transference and much more positive grandparent transference. All right, that was turning from the past. Now let me speculate on the future. What do I think is going to happen in the next 45 years, perhaps? We've learned from psychotherapy research that it's the common factors that are most important, particularly factors within the patient and the therapeutic relationship. If, however, you were going to pick a preferred psychotherapy for teenagers, I know CBT has gotten all the attention and all the funding and grant funding and research. I'm a big fan of IPT or interpersonal therapy and acceptance and commitment therapy or ACT. These have unique advantages for teenagers. IPT because it's so relationally focused. And teenagers are all about relationships. And IPT focuses on role disputes, social skill deficits, role transitions, and grief. These are things that teenagers are grappling with every day of their lives. And so IPT situates depression and anxiety in an interpersonal matrix. And acceptance and commitment therapy has a big impact on a big emphasis on values. And that is so important in teenagers, as you'll see when I come to the end. Values. I think in the future, so-called shared care models are going to have to become more the model of service delivery because there's not enough of us mental health professionals around. So if we share the care with pediatricians, nurses, general practitioners, we will get a bigger bang for our buck. We need to distribute our expertise while being careful not to diffuse our expertise. And I think another way to go in the future is through peer support and peer mentors and making more use of extended family, which is probably more easily swallowed or easily imagined in Europe than in North America, where we have this, I think, terrible individualistic, atomistic approach. And we rarely in North America consider enlisting uncles, aunts, grandparents as co-therapists. And I think that's a loss. Um, in certain underdeveloped countries where they don't have the luxury of psychiatrists and psychologists and social workers, they've enlisted grandmothers to become community-based mental health workers. Particularly in Zimbabwe, there's something called the Friendship Bench, which I encourage you to look up. But basically, grandmothers in Zimbabwe are trained to do problem-solving therapy, short for mild to moderate depression, and they hang out in community facilities, and this spreads the expertise in a wonderful, wonderful way. So the Friendship Bench. My goodness, technology, AI, chatbots, Fitbits and wearables are going to enhance the role, I think, of biofeedback. Maybe we'll have a post-DSM world. Maybe we'll get more sophisticated, as we already are in certain ways with, for instance, genetic profiling for medication, which offers the hope and the promise of what we all want, which is more personalized care. So I'm sure some of you have heard of GeneSight and gene testing for basically through a analysis of DNA and saliva, how do you metabolize different medications, antidepressants, antipsychotics, anti-anxiety. They can do it now for almost all medications. Simple, inexpensive. Send away a sample and you get back, oh, these are the medications you should use. These are the medications you shouldn't. I think it's a wonderful advance. We want to get to personalized care. Once you've seen one case of depression, you've seen one case of depression. So we have to tailor the treatment. And as far as I'm concerned, everybody is on some spectrum. So I hope in the next 40 years, we move away from categories and move much more towards what our psychology colleagues use, which is a dimensional approach, mild, moderate, severe, because everybody is on some spectrum. Ask not what disease the person has, but what person has the disease. That's variously attributed to either Hippocrates or Sir William Osler. Mental health, digital literacy, really, really important. There's a role for schools here. OWL stands for Optimizing Wellness Through Literature. One of my colleagues at Sunnybrook, Dr. Mark Senior, genius, has adapted Harry Potter for use in schools as a way to teach about CBT. So optimizing wellness through literature, he's basically getting the kids where they live, which is in school. Roots of Empathy, a wonderful primary prevention program created by a Toronto teacher, Mary Gordon, where mums with newborn babies take the babies into classrooms. This is primary school once a month. And with an instructor, they learn all about the development of a baby in the first year. This has been shown evidence-based to improve and enhance empathy. It reduces aggression, relational aggression, and improves perspective taking. And creativity kits, this is in the UK, again, a tool for promoting empathy. The role of government needs to step up here in terms of regulation, but also in the promulgation of things like mental health first aid. Just like we have defibrillators now everywhere, we need to train folks in mental health first aid and through the regulation of tech companies. The role of parents who currently get inadequate support and tech giants who I think we can never expect to regulate themselves. Virtual reality, e-therapies, chatbots, this is the next wave of the future. There's certainly the benefits to BITs or behavioral intervention technologies. As I mentioned, in terms of post-COVID, you know, technology does increase the accessibility for those who lack local resources, takes away the need for transportation, eliminates the need to take time off work, is more accessible for those with medical disabilities or psychiatric disorders that prevent in-person sessions, and it does reduce barriers. So it increases the potential reach of our interventions. And bots. So more and more kids, adolescents, are turning to bots for solace. Why is that? Machines allow us to reveal shameful feelings without shame. In some cases, a lack of humanness can be an advantage because they don't feel judged. Question, though, is who is the imagined audience? And here I think we need to just briefly refresh our notions of secure attachment, because my question is, can you be securely attached to a bot? Secure attachment is about visual, tactile, and auditory phenomena, a reciprocal attuned eye gaze, a loving touch, soothing words. Actually, bots now are doing pretty well at auditory. So patients are starting to rate bots as being more empathic than humans. Um, and they're starting to look more like humans. So far, we haven't gone into touch, but I think that's going to come. My question also is, how much more dependent will our teenage patients' children, in other words, grandchildren, be on devices that not only connect them with friends, like now, social media, but are their friends? In other words, will bots become their friends? If you want to read a wonderful novel about this, there's a book called Clara and the Sun by Kazuo Ishiguro. Came out about 5, 6 years ago. It's all about a teenage girl who strikes up an intimate, intense relationship, a friendship with basically a robot. So Clara and the Sun by Kazuo Ishiguro. Look, people are already having romantic relationships with bots. Um, they're falling in love with them. And, in Canada and North America, we've seen terrible outcomes. Kids, teenagers who are more vulnerable to this are committing suicide when the bot either doesn't reciprocate their love, or in one totally bizarre case, a bot actually wrote a suicide note for a kid, and the parents are suing the company, of course. So I have a number of questions. Are the teens today, adolescents, less comfortable with face-to-face interactions because their face is buried in the phone? Is it harder for them to read and accurately interpret nuanced facial expressions and body language? Again, because they're relating through a device. Do teens today have a good ability to regulate their emotions? Or are they just gonna, number four is, are they less likely to use people for soothing and comfort and more likely just numb themselves out by doom scrolling or playing video games?
Mm.
Will tomorrow's teens have avoidant attachment patterns because their parents, and I'm seeing this a lot, are using iPads as babysitters? If so, will they look like the neglected or abused kids of yesterday? So, parents, we set models of behavior. So, again, in the future, which presentation modality is going to be most effective? Now, this is for therapy, text, verbal, 3D avatar. What about transference to a bot? I think that's going to be a brand new field, and we don't know anything about that. Yeah, how and why do patients feel supported? What is the nature of a therapeutic alliance with a chatbot? Problems, of course, with confidentiality, security, liability, licensure, evaluation, and profit motive. Okay. Definitely harms from AI and chatbots, inappropriate, dangerous responses. And here we have culture too, right? In response to, and you can do this now with Alexa or Siri. If you say into your phone, I'm feeling sad, Canadian and some North American programs, the software says, I wish I had arms so I could give you a hug. That's pretty nice. But in Russia, if you say to your device, I'm sad, no one said life was about having fun. So that's kind of a cultural variations. And of course, potential harms are excessive attachment to and dependence on the device. And chatbots cannot empathize from lived experience. The kids don't realize this. Okay.
Mhm.
So, are we meaning mental health professionals and therapists, are we going to be out of a job, put out of a job because of bots, chatbots, and AI? I don't think so. And here's why, the next two slides. This is the best care, and I thank my colleague Zindel Siegel for these two slides. The best care for the most complex patients requires psychotherapeutic skills. So this is the effect size magnitude for psychotherapy. For the mild cases, it probably doesn't matter whether the therapy is being delivered by a less trained BA person or even a chatbot, because the effect size is pretty similar for a mild illness. But as you go from mild to moderate to severe, look what happens. The effect size in psychotherapy outcome for expertise goes up and up and up and up like this, whereas the effect size doesn't change for so-called distributed learning, which means therapy delivered by less trained people or chatbots. So the more complex your problem, the more you need an actual person. And similarly, this is a similar idea, effect sizes as a function of human contact. So if you get your therapy online only, and there are a bazillion apps now, CBT, DBT, it's all online. You can do the homework and everything. The effect size is pretty small. When you combine online with real live phone contact, it gets a little better. Online plus a real therapist, even better. And here, the best outcome, the effect size is biggest for good psychotherapy outcomes if you have a therapist, a real live human being, supplemented by online therapy. So these two slides together, I don't think we're going to be out of a job. It still requires patience. Okay, forgive me. I'm going to propose to you a new kind of mental status examination. Maybe we call this Marshall's mental status. I have a lot of problems with checklists and questionnaires, which is kind of that's one of my observations over the last 45 years is as therapists are more and more pressed for time, we're looking for shortcuts. And particularly the GPs and pediatricians are using questionnaires, the PHQ-9, the Beck Depression Inventory. Take your pick, but they're all 10 questions or less, tick, 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 and then the GP or pediatrician makes a diagnosis. Drives me nuts. I don't think that's good practice. So here's my proposal for look to the future of what kind of questions should we be asking our teenage patients? Who are your heroes? For which gender is growing up harder, girls or boys, and why? How is your generation different than previous generations? Is there anything special about being a teenager compared to a child or an adult? What do you worry about the most, and how do you cope with these worries? That would be pretty close to traditional mental status. To whom would you turn if you had a personal problem, a physical problem, a problem about a friend, problem about your parents? What's your opinion about psychiatry, psychiatrists, psychologists, social workers? How could we improve our image? Very interested in stigma. Who is somebody you admire? List three qualities that you admire about them. Describe an incident or event from which you learned a lesson the hard way. What could you change about yourself to become a better person? What three qualities do you value in a friend, a teacher, a parent? Describe a situation in which you went out of your way to help somebody else. Has life been good to you? Explain. Describe a situation in your life in which someone went out of their way to help you. Name 3 things for which you are thankful. Who's been most important in your life in helping you establish your values? Explain. Do you think you have a responsibility to help others who are less fortunate than you? And when you become a parent, what are the 3 most important values you hope you will transmit to your kids? Okay. These are the questions I think in the future we should be asking our teenagers. And before I close, we're getting into the conclusion here. Something that I only became aware of in, I'd say, the last 3 to 5 years of my career is basically the importance of sensory processing. So in North America, we have PDA. You may have heard of this. It's not a DSM diagnosis. It's either pathological demand avoidance or persistent demand for autonomy. It's often confused. Lots of kids who have oppositional defiant disorder, conduct disorder, ADHD, they're given those diagnoses when in fact it may be persistent demand for autonomy or demand avoidance, which actually represents sensory hyper or hyposensitivity. I think I've missed so many cases of sensory processing disorder as I look back. So now, before I retired, I started doing simple screens for, do bright lights bother you? Do loud noises bother you? Are you extra sensitive to touch? Can you wear wool? Taste, smell, and motion. So I do a screen, a sensory screen. I've referred a lot of kids who come to me with diagnoses with externalizing, sometimes internalizing disorders too, particularly anxiety. I refer them to an occupational therapist. Whoa, lo and behold, comes back, yes, they have a sensory processing disorder. The OT puts in some very simple things like wear earplugs or wear sunglasses. And all this so-called borderline emotional dysregulation disappears. Once the volume is turned down and they're thin skinned, they're given tools to make their skin thicker, they're not overwhelmed. And then they can regulate their emotions so much better. So think about sensory processing disorder. All right, to end up, some quotations that I think of reflecting on adolescent psychiatry. There are 2 ways of spreading light, to be the candle or the mirror that reflects it. I think in my years, the teenagers have been the candle, I've just been the mirror. Perhaps it is our imperfections that make us so perfect for one another. I think of that in terms of the therapeutic relationship. And I've often said to the teenager, look, I'm going to make goofs. You're going to make goofs. Can we forgive each other? And it's a wonderful, and I do that at the beginning. Ask not what's the matter with you, but what matters to you. That's the values. So important for adolescents. Some people think holding on makes us strong, but sometimes it's letting go. And I think of that in terms of coming to the end of therapy and termination. No man ever steps in the same river twice because it's not the same river and he's not the same man. That goes back thousands of years to Heraclitus. And I think of that for myself and for my teenage patients, particularly with trauma. It isn't always healthy to try and revisit the past. To be uncertain is to be uncomfortable, but to be certain is to be ridiculous. That's a Chinese proverb, very relevant for adolescence, which is all about uncertainty. Can I help you be more comfortable with uncertainty? And life isn't about finding yourself, it's about creating yourself. That's George Bernard Shaw. And heck, that's all about adolescent identity formation. A teacher is someone who walks in someone else's sleep. I love that. Um, we don't inherit the earth from our parents, we borrow it from our children. And lastly, it's never too late to be what you might have been. George Eliot, really a lesson for us all. So, in wrapping up, I'm going to say it's been a privilege to be the guardian of my patients' stories. I hope that I've helped them to feel seen, heard, and understood. I've borne witness to their struggles. And in so doing, I hope I've been a good companion so that they don't feel so alone. To me, that's a hallmark of good psychotherapy outcome is the patient feels seen, heard, understood, and not alone. They've taught me what it's like to be them. I hope I've been a good student. And my conversations with them are my souvenirs, and I will treasure them forever. That is it.
Uh,
Thank you.
Yeah. Thank you very much, indeed, Marshall. This has been an amazing presentation, you know, and you didn't just talk about your experience in 45 years, but, went through all the history of psychiatry and the future as well. And your suggestions were, uh, sounded very, very nice to me. And I'm sure they will be, very enlightening for the young colleagues, especially. So that's very nice of you, and putting all these together. I was thinking, there were, if we had a lot more time, it would be nice. I know we will need to go over many of the slides to discuss things, and talk about our different experiences about the issues. So I just want to have some time, a little bit more, perhaps, if there are, contributions or questions from the audience.
Yes, and regarding the slides, I'm comfortable if you circulate the slides to everybody who attended. I'm okay with the slides being available.
Uh,
So,
Okay, thank you very much. I think we'll put the recording on the website so that everybody can get it from there.
great. So yes, I'm happy to entertain questions for a few minutes if people
Yeah,
want to.
I'm sure there are people, who would like to contribute or ask.
I have to say I was too late because I could not go into the webinar. But what I got from you, I have to thank you. It was very, very interesting. And I liked very much your way of dealing with adolescents. And I thought it's really a big issue today, growing up as adolescents with all the problems with the internet. And I'm just working on the theory adolescence, and to look what's happening there, that such a little boy of 13 kills a girl. And I thought many of your thoughts have been into it just now. Thank you.
Mhm.
Good, you're welcome.
I don't have any questions, but I really enjoyed your listening to your experience, and I just want to say thank you. I especially like the last part where you mentioned new questions that's open-ended that can be discussed with adolescents. I'm definitely going to include that to my practice. So thank you.
You're welcome. Good, I'm glad.
Any other questions or comments? Okay. Thank you very much indeed, Marshall. It's been very nice. And yeah, and actually, aside from putting the video on the website, if you'd like to share the slides with me, because I don't have your slides.
Yes, I
So
will send them.
I can, yeah, I can circulate to groups within the association and to other groups of young colleagues, perhaps.
Yes, yes,
If you,
for sure.
yeah. Okay.
Okay, thank you.
Thank you
Bye.
all for
Thank you.
attending as
Thank
well,
you.
and hope
Okay.
to meet with all of you at another webinar.
Okay.
Bye
Thank
bye.
you.
Bye bye.
Bye.
Bye bye. Hi, Erico. I hope you're okay.